is Matt Thayer. I'm the orthopedic nurse coordinator at CHRISTUS Hospital St. Mary. How many people here have a problem with the knee? Show of hands. That's the most common, okay? How about problem with a hip? How about knee and a hip? I've always got somebody. Okay, I see somebody. These are the hip and knee pain seminars that we've been doing for quite a long time, you know, kind of off and on. And, it's been really good for the public. I think it's been good coming in, and we've had really good feedback. I think they get some really good information. I think they leave having a pretty good idea of you know, what the hip and knee pain, where it might be coming from, what things that they can do about it. And particularly, a lot of times it's not even surgical, but I think we've had really good feedback from the community. Okay. So what you're going to learn before you leave, okay? We're going to go over some normal knee and hip anatomy. We're going to keep it really basic, okay? And we've got pictures to kind of help everything along. Common causes of joint pain, okay? What's going on? And arthritis overview, obviously we got to talk about that, the big A. Types of pain, can be telling you different things, okay? And joint pain treatments, okay? Start off, let's go over the knee. This is where your femur, okay, your thigh bone, your shin bone, and your tibia here, okay, where they come together. And where our bones come together to make up a joint, you've got an articular cartilage, okay, which is this cushion, kind of cushioning type articular cartilage here, kind of spongy. It's very smooth, you know, bone on bone, as some people here are probably finding. It's grinding, very painful, not so fun. But a nice healthy joint, we've got a cartilage lining that goes around the end of the femur here, okay? And it actually goes around, over the top of the tibial plateau here where the femur meets the tibia. So cartilage on cartilage, nice smooth motion, no problems, okay? You've also got another type of cartilage specific to the knee, okay? And that's a meniscus, or more fibrous type of cartilage. You've got a lateral to the outside and a medial to the inside meniscus. And we can get some problems with that meniscus that can cause some joint pain that we're going to talk about as well. A tendon. Muscles connect to bones via tendon. Okay, the muscle contracts and pulls on the tendon, and then it pulls the muscle or moves the joint, flexes it or extends it. Okay, so right here, the big group of muscles is going to be the quadriceps. It's going to attach with a tendon right here to the patella, and ligaments, structurally the same. You know, strong cord-like fibrous connective tissue, but ligaments connect bones to bones, and tendons connect muscles to bones. Okay, now bursa. I don't really have a picture of this one in here. But I've got a slide where you get to see it. Bursa is a small fluid-filled sac, kind of strategically placed in the joint to kind of reduce friction and kind of cushion areas. And there's a bursa that's right here in front of the kneecap that sometimes can be an issue. And a synovium. We've kind of opened everything up here so you can kind of see inside the joint. But this is actually enclosed in a capsule or a synovium. Okay. And that lining of that joint is the synovium, and it actually produces a fluid called synovial fluid, which has a viscoelastic type quality, a shock absorbing and lubricating type quality to make everything nice and smooth and kind of oil everything in the joint, if you will. And there's some new things, well, relatively new, that also can help the synovial fluid, because it kind of loses that shock absorbing and lubricating type quality as we get older. So the hip. Same things you've got on the knee, you've got on the hip, except for that meniscus. All the things we just talked about, okay? This is just coming up, you know, the knee's down here, this is coming up to the other end of the femur, and we've got the head of the femur that goes into the socket. We call this the head of the femur, and we call this the acetabulum, or the socket of the hip, okay? So, just like before, where those bones come together, you've got a nice cartilage lining around that head. And inside that hip, you've got a nice articular cartilage aligning that socket, or that acetabulum. The large group of muscles with this is going to be our gluteals, and they're going to attach at different points to the hip is a ball and socket joint as opposed to a hinge joint like the knee. It's got a lot of different degrees of range of motion, so there's different attachment points, but those would attach to these muscles, to the bone with a tendon. And a bursa, there's one that really kind of comes into play sometimes. This is called, this part of the thick part of the hip here, okay, it's called the greater trochanter, and there's a bursa that's right out over here, and sometimes you can get an issue with that bursa and you get some pain right out here on the side. And we're going to talk about that a little bit too. We'll touch on that. And again, this joint has a synovial membrane lining this joint that produces a synovial fluid just like the knee. Not as big a quantity, but the same thing going on there. Now let's talk about what can go on. Let's talk about the torn meniscus, because this one is specific to the knee. That little fibrous cartilage, okay, you can get a tear Oftentimes this can be from an acute injury. Athletes will get this all the time, or you step wrong, or off a curve wrong, or you hit wrong, and the meniscus can get pinched between the femur and the tibia, and you can get a tear. And there's different ways it can tear, different places it can tear. A lot of times, I mean, it has a very, very limited capacity to repair itself. There's really not a lot of blood flow, to that meniscus. So if you get a meniscus tear that's causing you problems, that's when you're talking about, arthroscopic surgery. Bursitis in the knee. Remember I talked about that? There's that fluid-filled sac that's right over the kneecap or the patella. You can see this is very inflamed, and that'd be giving them some pain as opposed to this side. You can get a tendinitis. Oftentimes, here's our quadriceps muscle, comes down, attached to the patella, and it attaches right here to the little bump called the tibiotubercle in the front of the tibia. You can get some pain oftentimes with that. A lot of times you go out and hadn't done anything outside in a while, and kids' soccer's starting in the fall, and you're going out and kick the ball for an hour, and then you come back, my your knee. I've had that happen to me. So that's a lot of times a little patella tendinitis going on right there. That can be giving you some pain. Some synovitis. Here's kind of the lining of the joint. You can kind of see it from the side, and you can get an inflammation in the lining of that joint and in that fluid. And particularly people who have like rheumatoid arthritis. That's a very common thing. That's kind of the big issue with them, where it's actually attacking the joint, but it's very, very inflamed, called a synovitis. Anytime you see itis at the end of anything, usually inflammation or a problem with, so tendinitis, bursitis, inflammation of the tendon or inflammation of the bursa, inflammation of the synovium. And here's that greater trochanteric, bursa that I told you about. It can give people, problem right where that muscle kind of comes over around the side of that hip right there. There's the lining of the joint. You can kind of see it. You can get inflammation in the lining of that joint for that hip as well, and that's the synovial lining, the synovitis. Arthritis, a little bit different animal, okay? Remember our nice, shiny, smooth, articular cartilage? It's not looking as good anymore, okay? It's starting to wear away. The cartilage is being destroyed. And like I said, it's got a very limited capacity to repair itself, and you don't really get cartilage back that you've lost. You can kind of play with things, and there's some things that can maybe help you take what cartilage you've got left and make it more effective to maybe compensate a little bit for what you've lost, but you're not really getting cartilage back that you've lost. Once it's gone, it's gone. It's like the tread on a tire, okay? The most common, okay, there's two types. The most common is going to be osteoarthritis, the other being rheumatoid arthritis, which I kind of mentioned already a little bit. OA is just a wear and tear, or osteoarthritis is a wear and tear arthritis. It's been around long enough, been hard enough on our joints that nice cartilage lining, that tread on that tire, okay, whether it's here in the knee or whether it's over here in the hip, it's wearing out, okay? And once you've lost it, you're not getting it back. So now what you've got is you've got bone grinding on bone, and that gets very painful. And it's going to progressively get painful. And the more active you are, and particularly if you're somebody that's a big person, and is very active, just like your car, the harder you are on that tire, the faster that tread's going to wear out. Same thing with the cartilage, okay? Rheumatoid arthritis is an autoimmune disorder where the lining of the joint, the synovium, is actually attacking the joint, okay? And you can see some pretty bad disfigured joints in people that have really bad rheumatoid arthritis. Usually can be diagnosed with a blood test. There's a little factor that they can test. It's about 80% of the time, it'll be there and they can test. Anybody here diagnosed with rheumatoid arthritis? Good. Types of pain. If you've got a knee problem, that's where the pain is, okay? If the problem is in the knee, that's where it's going to be. It's not going to be, in the shoulder or the foot or the ankle. It's going to be right there, okay? If you've got a hip problem, it can be, depending on, what the problem is, if it's, like that bursa, it's going to be out here on the side. But if it's in the joint, like an arthritis, typically it's a groin pain, okay? You can have knee pain with a hip problem because there's a nerve that runs right by that hip, and it's very sensitive to to any inflammation, and it can pick up on that, and that nerve kind of goes right down to the knee. So you can have a knee problem that's irritating that nerve, or that nerve is sensitive to and picks up, and you wind up with knee pain. So there's been people who have come into the office thinking they had a knee problem. You work them up, and you're not really seeing any evidence that there's a knee problem. You work up the hip, find out that that's the root of the problem. So what can you do? Dietary recommendations, exercise, medications, over-the-counter prescription, surgical options, okay? Because you don't do that first, right? Diet, vitamin C rich. They think, you know, that it plays a role, that a healthy immune system plays a role in your having a healthy joint. Basically, you know, make sure you get your, you know, well balanced. You get your 4 food groups. We all know that from, you know, from school. Weight reduction, no. Don't forget you are what you eat. I need to eat a skinny person. That's probably the #1 thing you can do to increase the lifespan of your healthy joint. Now, if you're at your ideal weight, and I'm not talking to you, I'm talking to me, you know, and this is America. I'm talking to a lot of people. Like I said before, you know, the more active we are, the more weight we're carrying around, it's harder on that joint. That's just reality. It's going to wear out sooner than if, you know, we were at a healthier weight or having, you know, had less stress on that joint. It's a fact. In fact, they came out with some guidelines. It's been over a decade now, but they said the #1 thing, not surgery, not, you know, not medication, anything. And this is from the American Academy of Orthopedic Surgeons, the big professional group for all the orthopedic surgeons in America. They said the #1 thing you can do before you get to the point to where you need surgery to you know, prevent you from getting to that point or lengthen the time you know, before you get to that point is to lose weight. If you're carrying some extra weight, it would be to drop some pounds. Nothing else is going to help you better than that. There's a 2-hour rule I kind of like. If you feel worse 2 hours, you finish exercising, whatever that exercise is, okay? Whatever it is you like to do. And it's still hurting 2 hours after you finished, you're probably overdoing it. And the stress you're putting on your joint is probably, you're not, you know, I'm not going to take away from the benefit from the exercise. I mean, the cardiac, you know, the pulmonary, the range of motion, the strength in the joint, you know, the muscles, which helps with joint stability, all that's great. But just looking at it from a you know, the healthy joint, you know, and the amount of cartilage and what you might be doing to it, I would not say don't do any exercise, but I would modify. Do some, low impact is key, okay? Low impact is key. Something like a stationary bike is great. It's got that little tension wheel that you can tighten it all the way up, you know, like you're going up in the Alps, or you can, you know, loosen it all, you know, down to make it where you're you know, something to less stress on your joint. Jogging is no good, running no good. That's a big stress on your joints, okay? That's bad. Water exercises are great. You know, we don't, you know, the buoyancy, you know, our bodies have in the water. We don't have to put as much stress on the joint. Elliptical trainer is good. You just don't want to do that big loading, that big, you know, stress on the joints, whatever exercise you do, or maybe kind of break it up into shorter sessions so you're not putting as much on you at one time. Medications. Over-the-counter, prescription, injections, what's out there, what should you take? Let's talk about that a little bit. #1 family of drugs for arthritis. It's an inflammatory, you know, process. You know, like I said, it's got anything that's got that itis. So it's no big secret that the big family of drugs to treat are anti-inflammatory drugs. There's more specifically non-steroidal anti-inflammatory drugs. Okay? And the way that these work are by blocking the activity of an enzyme involved in the inflammation pathway. Okay? There's this whole cascade of things that happens, and it kind of blocks that, you know, one key part of it, so it suppresses inflammation in the body. And it's systemic, so I mean, wherever you take it, and it's going to work. If you've got a hip and a knee or a back, it's, you know, it's going to help with all of that. It's not something, you know, it's not going just to one specific spot. So, and there's kind of the second generation of those as well. You know, they call it the COX-2 inhibitors. Celebrex is a big one there, and the difference there is because these can have some issues with particularly stomach problems. People have had issues with, you know, ulcers or something like that. You also have an increase in, you know, stomach acid, so you're more likely to have, you know, issues there. So some people who maybe had bleeding ulcers or something in the past, they may not be a candidate for these. These are metabolized through your kidneys, so if you've got some kidney problems, your doctor may tell you, you know, don't take these, or if you had some issues, it's probably a good idea if you're taking these regularly. I don't mean just every now and then, because some people take these daily, okay? And there's, you know, Aleve is in there, ibuprofen, Cataflam, Voltaren, Celebrex. There's a bunch of them, you know, that fall into the category NSAIDs, or non-steroidal anti-inflammatory drugs. But if you're taking them regularly, you probably need to get a blood test every 3 months. And if you're getting blood work, you know, regularly, it's nothing special. It's just where they're just checking your kidney function just to make sure that the numbers don't go up. Because if they are going up and you aren't checking it, you can actually have some kidney damage with long-term, you know, unchecked use. So just be aware of that, because I've had some people that you know, had been an issue and had not been told that. Steroid injections. Anybody here had a cortisone shot before? Okay. And how did it work? Anybody get relief? Exactly. If it's something, you know, like a tendinitis or something like that, which is an acute flare-up, oftentimes it'll cure that, until the next time you go out, until next fall when you go out and kick the ball around, kick the soccer ball around, with a kid or the grandkid, and it flares up again. But something like an arthritis, which is a more chronic problem, you do still have flare-up, so it might bring the flare-up down, cool off the inflammation, decrease the pain, but it's not really treating the root problem, and that the cartilage is wearing away. But it can help it for it can be for months. It's usually a cortisone derivative such as Depomedrol. You can see here it's being injected right into the knee joint. And then this one, unlike the NSAIDs that you take, it's a pill that gets in your bloodstream and works in the body systemically. This has to get to the trouble spot. So if you go in and you're having knee pain and they inject your knee, but the pain's really coming from your hip, it's not going to really help the knee pain, is it? It has to go to the right spot, okay? And again, it decreases inflammation in the affected tissues, but it has to get to the affected tissues to work. And another thing, they're not going to do more than 3 to 4 injections in the same area per year. You don't want to overdo it. You can't, so you say, okay, well, I'll just go do that every couple of months. No, you won't. If it's only working for you a month or two, you need something else. But I've had people that did that for, they did it every 6 months, and that got them by, for years. But eventually they needed something more. Hyaluronan knee injections, that's kind of a mouthful. This is the rooster comb shot. Anybody heard of that one? How many people have had this? Okay, or something like never. Okay. Was it kind of thick? Is that what? Some people have said that, yeah. It's made from rooster combs. Remember I talked about the synovial fluid? It's got that viscoelastic type quality. It's got that shock absorbent lubricating type quality, which we lose a little bit as we get older. This is a synthetic form of that to kind of replenish that, restore that. Most of them are made from rooster combs. They have one that's not. Again, it's a synthetic form of that acid that's found in that synovial fluid, okay? Lubricant and a shock absorber. Usually a series of 3 injections. There is one that's 1. I think that one might be a little bit thicker. I've heard some of the patients telling me they usually think they want 1 shot more than 3 shots, but I've had people say they preferred 1 and it wasn't a big deal. But anyway, usually a series of 3 injections can last for months, okay? There's not much of a downside other than, you have to get a shot. I mean, it's not going to make, unlike, the the NSAIDs, have some side effects. This one doesn't, haven't heard much with this. Some of the brands, Synvis, Calgon, Orthovis, Suparts. Euflexa, if you've got like egg or poultry allergy, is one that they can give you as well. So how many people that had that got some relief with it? Yeah. I'd say most people. I'd say better than 80% of people, have had some relief with it, and it's one of those things that you can do, once it gets to a point where it's not working for you anymore. Then we get to, surgical options as we went through all kind of the more conservative things. We get a lot of people who are coming in who started having some knee and hip pain, who aren't necessarily surgical candidates, but it's become more than just a little nagging thing. It's starting to become a little more chronic. And then we have people who come in who they're probably are surgical candidates. There's a lot of things we talk about that are conservative therapies that may not work for them. They're already, we talk about diet and medications and over-the-counter and prescription, which obviously not surgical interventions. These people are probably maybe past that. But I'd say ideally really any of those, I guess. Anybody that's having any knee or hip pain, because there are things, we go through the plethora of different things that you can do. Not everything is just surgery. So before we get into total joint replacement, okay, we talk about arthroscopic knee surgery, because we kind of left that little torn meniscus kind of hanging out there. And total knee replacement we're going to talk about, and total hip as well. Arthroscopic surgery, okay, this is, your incisions are basically just as big as that. You have 2 to 3 incisions like that. And they're looking at through a camera, fiber optic, cord, and you can see there's a little tear in that meniscus right there. And like I said, it's got a very limited capacity to repair itself. And any kind of blood flow in the meniscus, it attaches over here, is going to be in that outer third there where it attaches. But this here, it's not going to heal. It's just going to continue to, it's going to get worse. It's going to flip up, and it's going to irritate, the joint. So what you do is you actually go in with a small little biter and you trim it off, just smooth it off. Okay. Now, does that mean you've got less cushion and cartilage in the joint? Yes. But at this point, it's a problem. It's not helping you. Okay? It's actually causing more inflammation. And it can speed up, and if you've got a joint that's constantly inflamed, it's just going to, it's going to speed up the arthritic process. So you're better off just taking that out. Knee replacement. Okay? Now people think that, that we go, and then take it and put in this big deal. It's a very, it's nothing like that. The incisions have gotten smaller, even though the implants, have gotten a little bit better. They're still, not smaller, but the techniques and the instrumentation we've used, to get these in, it certainly has been refined. It really is just a resurfacing procedure, though. Okay, you're taking as little bone as you have to, as you need to. So you're really just taking, you take a little bit off the end of the femur, a little bit off the front, and this is all. You have special guides to help you to make your cuts to make as little as possible, and so that it fits the patient. It's not a one-size-fits-all kind of deal. Okay, you have multiple different sizes available before you start your case. So, but when you make your cuts, it keys so that it fits perfectly, just onto the back of this prosthesis. Okay, and then you're going to take off just a few millimeters off the top part of the tibia, and you've got a base plate that sits there. So now these metal components here will actually be cemented to the bone with a bone cement. It's a grout, and it's rock solid in 13 minutes. It's not going anywhere. Okay, and then you've got a plastic liner that locks on to this metal base plate here, and then you don't replace the whole patella. You just resurface the back part of the kneecap, because the kneecap actually does track right here in the front part of this little groove of our femur, and there actually is some cartilage there and cartilage on the back of the kneecap. But typically that's also worn. So you replace that as well. So you've got two metal components and two plastic components. So instead of bone on bone, we've got a metal on polyethylene or plastic, but it's not just your typical, cheapo. It's melted, molded, remelted, highly cross-linked, different terms they use for it, but it's pretty solid stuff, and again, depending on how active you are and how big we are and things like that, but they've seen them last well over, even 20 years. So most people's first joint replacement, knee or hip, is their last one. It outlives them. Okay. You can take full weight right after surgery. Okay. A lot of times we get people up the day of surgery. Try to do them in the morning most of the times, and then get them up and do a small physical therapy session in the afternoon. Nothing too crazy. Sometimes it may just be consist of just standing up, or dangling on the bed and doing some exercises. Maybe taking a couple steps if people feel like they can. And then really kind of get them moving the next day after surgery. I'd say most people, better than 50% of people after a total knee replacement, if they have it on Monday, are going home by Wednesday. And the rest are probably by Thursday. So post-op day 2 for most, and the ones that don't go on the second day are going home by the third day after surgery. And surgery time is about 60 to 90 minutes, ballpark. Seems a little longer to the family, when you say goodbye and we go to there's other things involved, but the actual operating time, the surgery is about 75, 80 minutes. So you can kind of see, here's our before, not so pretty, okay? And you can kind of look at the after, okay? And you can kind of see it looking at it from the side, you can kind of get an idea, but we haven't taken much bone at all, and that's that metal base plate, and that's sitting down in the bone, okay? You don't see any of this part right here. And then this is just going just around the ends of the bone, and there's your kneecap. So, the amount of bone that you actually take out, you could fit in your, fits in a little cup or in your hand. So something is done to the patella also? Yes, you resurface the back of the patella. You don't take it out. It's not replaced, but it is resurfaced on the backside. And same concept, with the hip. Again, here usually it's the weight-bearing part of the hip up here in the top part of the hip, the superior part of the hip. Okay, you can see where that's not nice and smooth anymore. That would be painful to walk around on. But you put you actually take off the head. You've got a stem that fits down into the femur. Okay, these are not cemented. Okay, these are press fit and they kind of wedge in there. And then you've got a cup that goes up into the socket of the acetabulum, and it's got a plastic liner and a metal or ceramic head. We can get into some different bearing surfaces, and we'll talk about, Dr. Rice will probably bring that up too when he talks here in a little bit. But again, instead of a bone on bone, you've got a metal on plastic or a ceramic, in some instances maybe on plastic, weight-bearing surface, which is nice and smooth, and arthritis, no more. Usually, you can take full weight on the hip right out of surgery, 99% of the time. You can put all your weight right out of the gate, okay? And the surgery time is about an hour and a half. Pain management, that's a big concern. I know people that had joint replacements and heard horror stories. And people are scared about, they don't want to hurt. Even though they're hurting now, they're worried about, the surgical pain. It is a major concern, and we've got you know, the anesthesiologists are well aware and work with us, work with the patients to help take care of that for you after surgery. Using a combination of nerve blocks, particularly with the knees, and I think knees hurt more than hips, particularly, you know, you really want to get those patients moving as soon as you can, because if you don't, they're more likely to have issues after, you know, because if you don't move it, it'll scar down, and then it physically won't move later, and then we have to bring you back and do mean things to you to get it moving again, which we don't like to do that. But if you do your therapy, that's not a problem. But the nerve blocks are a big way to help, you know, help with that. Muscle strength, not as concerned with, that's going to come back. Main thing is you get that thing, get it moving and keep it moving early as we can. But combination of that, IV pain medications, some of those are narcotics, you know, like Demerol or morphine, some non-narcotics, which are kind of like anti-inflammatories to help, oral pain medications, a combination of all that so that you have as little pain as possible. And I think with a good block, I know, you know, before we used to use them, you know, years ago, I think right now, you know, probably the gold standard. I haven't seen anything better. I know there's other things out there, but that works pretty good. Okay, so talking about what makes it different here than other places, okay? It's a different philosophy, you know, at the Joint Replacement Center here. You're not just another sick patient, okay? You're our client. It's kind of how we've taught the staff here to look at things, you know, to have a different mindset about it. You're our guest, okay? We've got nurses that have been here for, you know, some of them decades, you know, and they know what they're doing. You know, we've got a really good team of people here. You're not just our patient, you're our client. We're here to serve you. And the patient satisfaction scores here, you know, every hospital, every facility, you know, does patient satisfaction scores on their units. And if you're an inpatient unit and your satisfaction scores are above 90, I think they say that you're doing pretty good. The ones here are like 98, 99. I mean, they're ridiculous, really. I've not seen anything anywhere, you know, where the patient satisfaction scores are as high as they are here. Some of the different stuff we have here, years ago, we used to have those semi-private rooms. Everybody in those, you know, we had the curtain room between them, you know, where you had two patients in one room. Patients hated them. We took those, made them big private rooms, and those are our joint suites. Like I said, they're twice the size of a hospital room. You know, we got Wi-Fi, we got, you know, nice, you know, new beds and furniture for the family to stay with them and store their belongings. The nurse-to-patient ratio, some places they've got, you know, 8 patients to 1 nurse. You know, and if they've got 1 or 2 patients that are, you know, have things going on, you know, good luck seeing your nurse, you know, that often. Here, they may have 2 patients, you know, to a nurse. You're getting taken care of. You're not calling the button and waiting an hour to get, you know, to see somebody. They're right there. If anything, you may be saying, "I'm fine, leave me alone," you know, which you don't get anywhere else. And also the joint suites, which are just on the other side here of this wall. This is our physical therapy atrium, okay? But the rooms have a special door that goes right into the physical therapy atrium where you're going to do your physical therapy. So should you see a specialist? Well, is your joint hurt 1 or more days per week? Is it interfering with your sleep? Painful to walk more than a block? Pain medication's not working anymore? Is it limiting participation in activities, family vacations? Is it pain keeping you from living and doing the things that you want to do and need to do? And has it caused inactivity from joint pain caused you to gain weight? If you're answering any of those, yes to any of those questions, you don't need to live in pain. There are things you can do to take control over knee and hip pain and take charge of your life again. The information that's out there in the public, even with the internet, there's so much out there, and there's so much, I think there's a lot of misinformation as well. I think coming in and hearing from people, you know, like, you know, myself, who've been doing it for over 20 years, the orthopedic surgeons, the physical therapy staff, I think it makes a huge difference. I think it clarifies it for people. They really get a better understanding of exactly what's involved, what's going on with them, what's involved in the treatment plan, even if it is surgery, and what involved. And there's a lot of fears, because a lot of people come in, they are candidates for surgery, but they're afraid. You know, there's a lot of unknown, and I think we clear up a lot of that, the fear of the unknown with these classes. So, without further ado, we have Dr. John Easton, one of our orthopedic surgeons here with us, okay? And he will be here, and if you have any questions.
Thank you, Matthew.
Hello, you're welcome.
Thank you. All right, thank you. So how long have you been here?
Oh, Geez.
St. Mary's?
Since 92.
Okay.
In varying
Matt's
capacities.
been here since 92, and I've been here since 90, so we've been working together for about 20 years. So, my name is John Eyston. I'm one of the orthopedic surgeons here at St. Mary's. I have an office in Port Arthur, and we see people here for the last 25 years. A lot of people have got a lot of outside influences, their friends, their neighbors, the newspaper, the TV, and they're really not sure what they're getting into. They're not sure about what they've heard, and it's a way in a group to answer their questions, spend an hour going over exactly what's going on, telling them a little bit what to expect, and trying to let them know what the facts are, sort of the way we see it anyway, on a professional point of view as opposed to in the papers and that sort of thing. Probably 10, 20 years ago, this was a 10-day hospital stay. You stayed in traction, you know, the beds. So what's happened in medicine as a whole, and orthopedics as well, is that this is a lot more refined, and the way we've looked at it as far as pain control, as far as rehabilitation, we get people moving a lot quicker. There's a movement across the country now to try and get people in and out the same day for joint replacement. So it's really a huge deal, and I think that's been probably the biggest change in the last 10 or 15 years of doing joint replacements. So I think they don't realize that we expect them to be out in most cases in 48 hours, and by the time they're leaving, they're walking, they're getting up and going to the bathroom, they're going up and downstairs in 48 hours. Where we are, we're outside Houston, a big center, so I think a lot of people are saying, well, that they probably don't know how to do it here, we have to go to Houston, and so I think we try and tell them that, we've been around, we all trained in the same place, we all do the same prosthesis, we all go to the same meetings, and so I think it's just clearing up misconceptions. We're part of Bone and Joint, which is connected with CHRISTUS, so they could contact us through our office here.